How y'all doing? It's Jenny from America. I'm going to give you just a one-day thing on baby I here. Very, very concerning situation going on here. Michael McConville, in his incredible podcast, I will try to link him in the description if I am unable to. I encourage you to listen to the October 16th, 2024 and October 20th, 2024. In October 20th, he basically does a wonderful thing. He basically names this baby essentially something called the collusion of anonymity, which actually happens here in America too. And basically what it is that so many people are involved in the situation, yet no one takes responsibility. They all pass it on to someone else. The taking direction of the care of the patient, or I should say ownership, again, is passed on to that next person. No one gives a damn enough to take it. And again, I've seen it time and time again where people were either misdiagnosed or their symptoms were poo-pooed, especially in women. I have noticed this. Now, I am going to Americanize it and basically say this is just like the scene in Gone with the Wind. If you've seen that movie, and the last scene, basically Rhett is leaving Scarlett and he's going out the door, and she says, "Oh, Rhett, what shall I do? Where shall I go?" And he basically looks at her and says, "Frankly, I don't give a damn." And to me, that's what I'm naming this baby. No one seemed to, in all, the whole that network that was in the northern area network, no one seemed to give a damn, including the consultants and including the people in the thing also. Now you're seeing the table shake here. That is Empress. She just jumped off the table. So what is going on with this baby? It was 2.5 months of sheer torture and hell for it. Basically, it had 5 transfers between 4 different places: Liverpool Women's Hospital, Countess of Chester, Arrow Park, and Alderhay. The baby was a 27-weeker. Mom's membranes ruptured weeks before it was delivered. And even though there is not an infection that goes on, maybe the bacteria did not go hurt the baby. What happens is that the fact that the membranes have ruptured, the membranes have a jagged edge on them. Anytime the body sees something that's just not quite right, it does an inflammatory response. So the baby was born at 27 weeks, which is considered extremely premature, with premature lungs, but it also had a lot of the inflammatory response issues in it. And again, as we know, the inflammatory response on a baby is just, it goes out of whack. It isn't. Now, what happens is this baby had something called bronchopulmonary dysplasia. And as you can tell right here, this is the end sacs. Basically, your lung branches off into many branches, and the end of it here are those little tiny alveoli, those sacs. This is where the oxygen and carbon dioxide are exchanged. So now you can see here, that would be a damaged lung. It is collapsed. It can't expand correctly, but it also retains things, and it can't collapse correctly. That's very important. Now, one of the major causes of this are prematurity, mechanical ventilation. Again, this is where you have to be such a skilled person at this. The breathing machines, again, if you're not very precise on the pressures that you use, you can damage that delicate tissue. But look at how here, this baby always had a lot of oxygen. And remember what I've been harping on you all? High oxygen concentration will damage cells. Now the baby went through multiple transfers, as you can see here. Look at all that's going on here. All the transfers back and forth. Basically, there is it has a lot of issues with neck. That's the necrotizing enterocolitis. You absolutely expect that. Also, they have that on premature babies too. Now, what we're going to do is we're going to focus on this area right here. This is the one that seemed to kind of bit on me. It was look at October 13th to the 15th. So it lingered. Look at how long it lingered at the Countess of Chester. Okay. Now, what Shuley is saying is that it basically this was the one where it was colonized with Steinomonas multifila. And Liz Hall, Shuley says, and it wasn't Shuley saying this. People saying it was Shuley. No. On Shuley's panel was a noted pediatric infectious disease physician. And I do apologize, I don't have her name on the tip of my tongue here, but she's a well-recognized, well-known Canadian infectious disease pediatrician. She's the one that noticed that colonization. Again, you don't have to be infected with this type of pathogen to be affected by it. Meaning, this is a first or second cousin to Pseudomonas. And like Pseudomonas, what does it do? It produces a biofilm, sticky goo that protects itself. Not only does it protect itself, but it encourages other pathogens to come all on board and just to party along with them. And that sticky biofilm, what does it produce? This baby had multiple issues with respiratory status. It had severe sticky mucus. Even the junior doctors were saying, no, this is more sticky and more goopy than we would expect a regular mucus to be on a baby. That's what part of that was. That was part of that biofilm. So no, it may not have technically infected the baby, but the fact that it was in its, they were able to detect it in its breathing tube. In that breathing tube, it was producing that biofilm along with the regular mucus you would have. Anytime you have a tube down anyone's throat, you can guarantee you're going to get mucus. More mucus than you normally would. Now, basically, also this baby had issues with ileus. The family had a history of, lactose intolerance. It was going to be worked up for that and worked up for various other GI issues, but unfortunately, it never got around to it because it died before they were able to finish all the GI workup on that. Also, I believe this was the mother that basically was very upset when she would see a nurse that was sick and taking care of the baby. Let me tell you, yes, as a nurse, your bosses tell you, do not come in sick. But what they also say is, you have to come in no matter what. So it literally is a no-win situation for people in the healthcare facility. They look at you and they count your sick days. So even though they tell you not to come in sick, you better come in, if you get my drift, because we're always understaffed. Now, I'm going to do me some charting here, and basically, let's say this is, I'm highlighting just that area here that Brewery said. And basically, it said treated conservatively for neck, arrested on the 13th, 14th, and 15th. It had 3 arrests over this period. It's saying there's rapid improvement after each arrest. Ugh, I'm so doubting that. They may think it was improvement, but it would not have arrested again if it was so stable. Discussion with neonatologists rather than or as well as surgeon would have been appropriate on the 13th. They waited till later on to call Alderhay And Alderhay said, we don't think it's neck that's going on with the baby. And besides, you've transferred this baby in a previous time and it wasn't neck. So it's kind of one of they poo-pooed him. They went and called Liverpool Women's Hospital for some advice. And this is where Yaxel took 7 hours to call them back. Now, eventually it was transferred to Arrow Park. But again, look at what it went through all these days. I am absolutely disgusted with that. Now here is the, here is the Cheshire Merseyside Neonatal Network. They did a tabletop review on this baby. Okay, now let's go through this right here. October the 13th, found blue and apneic and cot. CPR, 3 doses of adrenaline. That's the jump start the heart. Bicarb, because it knew it was in metabolic acidosis. That's a treatment for it. And for some reason, I guess it gave it a fluid bolus of sodium chloride in the IV. Heart rate greater than 100. Ventilated and added, look at this med here, that's Flagyl. They give that for anaerobic pathogens. Anaerobic pathogens are found in the gut. Where is gut bacteria found? Mostly in a hospital, in sewage. And look at this medication here, ciprofloxacin. The class of medication this comes from, I think it's fluoroquinins. I do apologize. My pronunciations have gotten real bad. But anyhow, the class of medication this is used for, it's used for several different pathogens, but one of the pathogens it's used for is Pseudomonas. It required a blood transfusion, marked bowel loop distension on abdominal x-rays, dobutamine. That is a critical care medicine that's used to stabilize your blood pressure, and it also is an aid to help your heart beat better, strengthen your heart. Remember, they had to give it adrenaline. So they started IV dobutamine on that too. That should only be in an intensive care situation by skilled people who know what they do. There are some instances in adults where you can give it a low dose on certain adults that have what we call heart failure. The muscle's just not doing what it needs to do. But if you, and I'm assuming it gave it for blood pressure and cardiac stability, in that instances, it cannot be done on what we would call a telemetry floor. For the low dose, it has to be in an intensive care situation. Again, what does it do the next day? Arrest again. Abdomen distended and mottled, desaturating on ventilator. So they discuss with Alderhay surgeons, and again, they don't say that they waited. Look at how long they waited to do that. Dobutamine stopped. Gases of ABG's better. Opinion from Liverpool Women's Hospital consultants, that would have been Yaxel, transferred not indicated at this time. Again, this would have been Dr. B or Dr. V, you know, the one that didn't know what she was doing. And baby Noah died in 2014. She was the one that had called them. Again, are they being straight and narrow with these guys here? Are they being open with what's going on there? Or are they doing instead a sort of a Ravi, if you get my drift? Just giving them just a little bit, not giving them the whole thing. Again, so they believe the baby is stable enough to stay here. Again, if they would have given him the whole thing, again, it's Yaxel. Again, but we don't know. It's Dr. Yaxel. Again, this baby is constantly going back and forth to all these hospitals. And again, I hate to say this, but we've had patients that we've had to, sometimes when they go back and forth, or what we would call constant admissions, and I hate to say this, it happens in nursing as well as medicine. You get tired of it. You want to turf them off to someone else. You want that other person to take on that problem so you don't have to. Again, the next day, it desats on vents. Look at this, pancuronium. My previous thing, I told you about this medication. This is the paralyzing medication. This medication is used as part of the lethal injection cocktail in America. If you're on death row and you're given the death penalty, this would be one of the medications. If not that, it's one of the cousins, something closer to that, to paralyze you. Now, there are appropriate situations where this needs to be given. Sometimes you need to paralyze someone in order to sedate them, paralyze them enough so you can get that ET tube down their windpipe. But only the most skilled human being should be doing that. An anesthesiologist, an anesthetist, could be a nurse anesthetist under the direction of an anesthesiologist. They don't work alone. Critical care physician, neonatologist, an emergency room doctor, which essentially an emergency or an A&E doctor. They are skilled. They have to be also skilled critical care. Do you think the consultants at the Countess of Chester Hospital should have been anywhere near this medication? Now look at that, right lung collapse. What is that telling me there? They didn't ventilate it correctly. They did not ventilate. They were either giving it too much air, too much pressure, or basically only giving the correct ventilation in the left lung, and so the right lung collapsed. We don't know. Again, the person that's taking care of this is the person that allowed baby Noah to die. Thick secretions. Now, Arrow Park Hospital discussion suggests regular saline, suction. Again, this would be IV fluid boluses, suction, reintubated, ventilating, needing 70% FiO2. Again, what I wouldn't give to have someone like a Colin Morley, a Shu Lee, a Richard Taylor standing right next to me and telling me, Jenny, it's okay that they gave it 70%. I'm scared. Again, this is when, if I would see this in a chart, I would go back to my neonatal intensive care unit, grab a good neonatal unit nurse or the neonatologist and say, explain. Again, we know with bronchopulmonary hyperplasia, too much oxygen is going to destroy that. Further, DSAT and bradycardia, CPR again, discussed with tertiary. Finally, Liverpool Women's Hospital agrees to transfer, and Arrow Park comes and gets that baby. Now they transfer that baby to Arrow Park Hospital on the 15th, basically recovered, and they advised conservative treatment, and it comes back, look, October the 17th, it came back to die. It wasn't treated well, and it dies only on the 23rd. Remember, I'm telling you, I'm scared to death when it comes to Harkness. He doesn't know what the crap he's doing at Register. In his witness statement here, this is some of my writing here. While everyone is saying it was dobutamine, he's saying he's dopamine. The baby could have been given both of these medications. Yes, it sounds alike, but every nurse and physician knows that they are two different medications. Yes, they are cousins, but you do not confuse dopamine with dobutamine. I'm questioning how intelligent this man was. In his witness statement, was he so stupid that he said dopamine? This is not a technical error, people. This is not a transcription thing. This is either he is telling us that we don't know that the baby required not one, but two different critical care medications. Granted, they are very, very similar, but again, there's enough difference in them that you would know the difference between them. Or is he just plain stupid? I'm going to go for stupid. Now, let's look on to this. This is what the consultant sent over to Operation Hummingbird, and this is how they describe it. 1 month later, found blue and apneic. Responded to resuscitation. When I just spoke to you, did that sound like that baby responded to resuscitation? Treated for neck or infection. Following day 5, further arrest and distended abdomen. Responded to resuscitation? Does that sound like they responded to resuscitation? Following day at 4 o'clock, Further arrest and resuscitation. Finally transferred to Aero Park. Improved and no further deteriorations. Yes, it got what it needed at Aero Park. And back to the Countess of Chester 3 days later, which in a matter of a week or days, that poor little baby died. Now, here is what in that area here. Here is what Dowie Evans is saying. That's all that what I tell you here. Now he's basically describing all the stuff that happened before and all the stuff that happened after. All that stuff I discussed, that's all he's saying. Not improving to Aero Park. He completely, absolutely diverts from what all that happened. Specifically, this is what he is telling that detective. He is absolutely, and this is not stupidity. He did this on purpose. He purposely disregarded all that information and kept it from the detectives to cover up for these bastard consultants. Now look at this here. Oh, and he's just describing the death here. Intravenous would have killed, but also hand over mouth would kill too. Now, if this wasn't torture, I don't know what was. Absolute torture. And the fact that now I'm finding, I have now lost count on the number of babies that I've seen having pancuronium. That's that anesthesia med that was given, that should only be given by skilled people. I've lost count. It's been so many. Now that was a medication that I was also given when I had a pretty involved GI surgery a few months ago. I was given correctly. They had to completely paralyze me in order to paralyze my abdominal muscles, but also my breathing muscles. So they could then put me on a breathing machine and put me into the deepest of deepest anesthesia. So that wonderful, wonderful surgeon I had, who I jokingly referred to as God, could work his magic, could go really deep into my gut and take care of me and do a beautiful job. As I told you before, I just had my colonoscopy by my gastroenterologist. He was the one that turfed me over to this wonderful surgeon. And right before he put me out, I had a nice little talk with him and told him, because he had not seen me since my surgery, and he asked me how I did. And I absolutely thanked him. And if I wasn't connected to 1,000 monitors and IVs and everything that you need for a colonoscopy, I would have given that man the world's biggest hug for doing the right thing and turfing me correctly to someone he knew that would take beautiful care for me. And then what did he do? He then followed up with me just for my, I purposely made sure that I had him for my, just that routine colonoscopy that you gotta have every so often as a screening. And he's going to take care of me for the rest of my life, or the rest of his career, I should say. And I know that I will be in good hands. He's taking responsibility for my GI issues. And no one took responsibility for this baby. In fact, what they said to this baby, every single human being on that Merseyside and Cheshire thing said, frankly, I don't give a damn to that baby, and shame on them. Bye-bye.